I think we'll get started. Ross Garberich is sick today, so we're only going to have 3 presentations, so we should have plenty of time for questions, but nonetheless 3 excellent presentations. And so the slide here shows some of our recent research through the foundation, with the main focus being on the upcoming ACC conference, which is next weekend in Orlando. And once again, we have an excellent presence. We have 34 posters there this year and multiple other presentations, so should be an excellent showing for the foundation. And I want to highlight one other study that we're starting here at the foundation. Andrew Burns is a psychiatrist who's at Hennepin County Hospital. He recently came there from Brown University. He's done some really interesting research on post-MI counseling for depression and for smoking cessation. And so he actually has a fully funded NIH trial to look at intervention. It's kind of a combination of inpatient and outpatient counseling for smoking cessation after MI, or after ACS. And so he's got a fully funded NIH trial, and when he went to Hennepin, he was going to be short on enrollment. So he got put in contact with us, and so I'm the principal investigator for this site, and we are going to be hopefully the main enrolling site for the PACES study, which is one of the very first randomized trials to look at if intensive smoking cessation counseling in the inpatient that then transfers into the outpatient. So one of the issues has been people get inpatient counseling and then they leave the hospital and they don't have any follow-up. By the time they're seen by their primary care, they're already smoking again. And the other studies have looked at outpatient counseling, but by the time they get to their primary care, it's been a month and they're already smoking again. And so this really looks at inpatient to outpatient counseling to really kind of keep them accountable through that process. And so it's a really unique, well-designed trial. And so we're happy to be a part of it. We enrolled our first patient last week. So if you have anybody with an acute coronary syndrome that's going to the cath lab, and if they are smoking when they come in, this would be a trial we should definitely consider. We definitely want to enroll as many as we can. So should be an exciting study for MHI. So up first is Angie Lobo. So Angie is one of our second-year residents here at Abbott, and she's been doing research with our group for a while. She started with Dr. Marin and now has transitioned to some other work, and she's applying for cardiology fellowship this year. And so best of luck with that. And she's going to talk to us about sleep deprivation in cardiology. And I'm on call tonight, so this is very relevant to me. So I'm curious to see what she's going to have to say.
Thank you. Good morning, and I was on call last night, so I'm a living example of sleep deprivation. Thank you for having me here. This is our abstract that will be presented at the American College of Cardiology this upcoming weekend, and it's titled Sleep Deprivation in Cardiology. It's a multidisciplinary survey. These are our authors. Our principal investigator is Dr. Berlakis. These are our disclosures. So what led us to study this was the burden and impact of sleep deprivation in cardiology has received a very limited study. So what is sleep? So sleep is a reversible state of reduced responsiveness, motor activity, and metabolism that we know it's necessary and essential for life and optimal health. And also we know that sleep is related to metabolism, cognitive performance, and safety-related performance. So I would say it's pretty important to cardiology. So expert consensus has recommended that adults should sleep at least 7 hours on a regular night. And consistently sleeping less than 7 hours per night has been associated with numerous adverse health outcomes, including type 2 diabetes, cardiovascular disease, hypertension, weight gain and obesity, depression, impaired immune system, and it does increase the risk factor of death. So what studies have been done in cardiology in the past? So we know that the largest study was performed by the National Cardiovascular Data Registry by Arnaud et al. In 2015. And what it did, it compared in-hospital mortality and bleeding complications from PCI in operators who were sleep-deprived versus non-sleep deprived operators. So with this study, they were not able to show any difference between sleep-deprived operators and non-sleep deprived operators. It also compared whether the degree of sleep deprivation had an impact in clinical outcomes among the sleep deprived. So it compared acute sleep deprivation that was usually accounted for having to perform a PCI between midnight and 6 a.m. and chronic sleep deprivation having to perform PCIs at least in 2 occasions within the last 7 days between midnight and 6 a.m. So what it did show that there was no significant relationship between acute sleep deprivation and adjusted risk bleeding and mortality. Conversely, the procedures that were done by chronic sleep-deprived operators were not associated with increased mortality. However, they were associated with a significant greater adjusted risk of bleeding. So our study objective is to improve the understanding and the burden of sleep deprivation in cardiology. Our design is a multidisciplinary online-based survey on sleep health pattern and potential impact of sleep deprivation. It involves 44 closed-ended questions that were distributed via email. Our population were cardiovascular providers involving physicians, nurses, and technicians. So we sent out a total of 6,683 emails, for which 481 responded and completed the survey. And out of those 481 respondents, 70% were interventional cardiologists. What we found is that 80% of our respondents were male, 91% had call responsibility, including 43% having more than 7 call nights per month, and sleep disorders were reported by 25%. Within those 25% said yes to using sleep-inducing medications, including 8.4% at least once per week. So our main factors that affected the quantity and quality of sleep were mainly related to work in 66% of the respondents. 56% of the respondents were affected by family or personal activities, and 48 were staying up late, writing, or studying. Sleep deprivation was associated with increased irritability in 68% of the respondents, difficult concentrating in 58%, and a lack of motivation due to sleep deprivation in 56% of the respondents. So interestingly, work performance was felt to be hindered in 46% of the participants. And I want to have your attention here that 8.6% of our respondents reported an adverse event related to sleep deprivation. So our adverse events were classified those that were directly affecting the respondent, those that affected procedure, decision-making, and patient-related. Those that affected the respondent were mostly related to motor vehicle accidents, reckless driving, and mood changes such as irritability. Those that affected the procedure included procedural complications as pacer perforations, vessel dissections or vessel perforation, longer procedural time, difficult access, delayed reaction, failed interventions, and lack of patience, especially with fellows. Decision-making capacity was affected. It altered the management and therapeutic plan. They staged procedures, canceled cases, rushed through procedures. It also impaired decision-making, such as misdiagnosis, erroneous interpretation of EKGs, and impaired concentration. They had difficult time charting. And those that affected patients are those procedure complications that directly affect the patient, and major adverse events were reported, including death. So many of our respondents, almost 57%, felt burned out, and 85% had the opinion that policies should exist that allow sleep-deprived providers or staff to go home early post-call. So our conclusions is that our survey provides insights into sleep health patterns among cardiovascular workers and potential factors contributing to sleep deprivation. Sleep deprivation may impact the performance, with above 8% of respondents reporting an adverse event related to sleep deprivation. We know that now that more study is required to both identify measures to attenuate the burden and better understand the impact that sleep deprivation has in both healthcare and the patient. This will be the poster I'll be presenting this upcoming weekend in ACC. Thank you very much. Any questions?
Any questions?
Is there any way to have a control group or some control data? So you mentioned 6% are drive burnout. Well, that in the general physician population, that's about the number that.
That's a good question. And I think, the fact that you got that many interventional cardiologists to respond, I think that indicates it's something they consider a serious issue.
Thank you very much for responding.
A simple question, but when you see the population and the large percent of interventional cardiologists, where did you start? What was the spread of that original population that you sent the survey out to?
So it included pretty much the whole team. It included echocardiographers, it included technicians, it included lab technicians, it included nurses. And in cardiovascular, it included general cardiology, all these subspecialties of cardiology, and it also included CV surgeons. Thank you.
Thank you. All right, our second speaker, our presenter, is Cody Pope, who is a sophomore at the University of Minnesota, a biochemistry major, and he was one of our 2017 summer interns. He's been working with Mario Gasol on some work looking at complications from transfemoral TAVR. Cody?
All right. Hello, everyone. It's great to be here again. Thanks so much, Dr. Miedema, for the kind introduction. I'm Cody Ho. I was a former intern this last summer. Speaking of which, I'm really missing right now because speaking of which, I'm really missing right now because of the inclement weather that's going to be coming around here today. But I'd like to present our findings on a project I did with Dr. Gusso and Sarah Olson on an evaluation for risk factors for vascular complication severity during transfemoral transcatheter aortic valve replacement. So transcatheter aortic valve replacement is a procedure that's aimed to treat aortic valve stenosis, which is a narrowing of the aortic valve. And this is most often caused by development of calcium or calcification on the valve itself. And patients generally see symptoms such as chest pain, heart failure, and syncope. And in fact, according to the U.S. Census Bureau, as much as 2.5 million Americans over the age of 75 have some form of aortic stenosis. 1 in 8 of those patients can be classified as having moderate to severe aortic stenosis, and in that population, the mortality risk is 50% after 2 years and as high as 80% after 5 years. And so as our population in the U.S. ages, aortic stenosis is going to become an ever more increasing public health concern. So how are these procedures then performed? So the gold standard is surgical aortic valve replacement, or SAVR, but in patients that are more frail or have higher surgery risk, this is probably not the best option. Sternotomy is not the best approach or optimal approach. And so instead, many opt for the transcatheter delivery of the aortic valve. And most of these are performed inserted at the common femoral artery here at the groin region, so just around here, either leg. And a lot of these are punctured through a percutaneous access. So an interventionist will go in with the help of ultrasound, fluoroscopy, or angiography, kind of find that site, puncture it with the needle, and put the catheter in that way. This superseded the older approach, which was surgical cut down, which a surgeon would come in and cut down at the site, because when you expose the skin, that has a risk of wound infection. However, the biggest one of the biggest obstacles to the success of TAVR is vascular complications, and because many of these percutaneous accesses use percutaneous closure devices. So these help close that hole that the interventionalists have just made into that artery at the beginning of the procedure, so that right at the end of the procedure, once they've done their magic at the heart, replace the aortic valve, they can shut that immediately and achieve hemostasis quickly. When these devices fail, you might have to put another device in. Sometimes the patient might bleed there and develop a hematoma, so that would be a minor vascular complication. And if the site isn't closed completely and there's bleeding there, sometimes they might bleed into the abdominal cavity. That might be a major vascular complication, and those are often fatal. And so what we wanted to look at is, are there demographics and CTA, so computed tomography angiography data that could help show us, well, in this patient, maybe they have an increased risk for a major complication. Maybe it's not such a good idea to use a vascular closure device, and we should use surgical cut-down instead. So we hypothesized that a combination of demographic and CT data would help us find those patients. So in our methods, we screened all percutaneous transfemoral TAVR patients performed at Abbott Northwestern. Of the population size of 481, and we screened for the transfemoral axes. And then out of those, we found the patients that had vascular complications. So this was sorted by BARC2 criteria. So these are criteria that indicate if a patient has a device failure or a minor vascular complication or a major vascular complication. Then we looked at the demographic data of each patient and also looked at CT data. So in previous literature, we've seen that factors such as tortuosity of the vessel at the access site, calcification at the vessel site, are indicative of vascular complications. But we also introduced a novel measurement, which was measuring the depth of the skin, so from the surface of the skin to that vessel, both vertically, directly above at 90 degrees as well as 45 degrees, because often these devices are placed 45 degrees downward. So we wanted to integrate these lengths into our measurements and see perhaps if those measurements are indicative of severity. And then we performed statistical analyses on these data. So our results showed that many of our patients were high age, so around 80, 90 years old. They had intermediate STS surgery risk scores, and many of them were in the overweight to obese range in BMI. We found some interesting results regarding trends as to the severity and of vascular complications. So down here we see that those who have a higher 45-degree depth from the access site may be more likely to get a device failure complication. It's, also referencing earlier literature, higher tortuosity at the central femoral artery might be associated with a higher rate of major vascular complications. However, when we did the statistical comparisons, we did not find any statistically significant differences between the two groups. So, in conclusion, we found no strong association in our CTA and demographic factors that would show which, if one group would have one sort of complication over the other. However, we did show trends that said, yes, increased depth at 45 degrees may increase the risk of device failure. And this means that interventionalists and radiologists might not have to spend so much time looking at CTA data when selecting patients. It takes a lot of time on the patients on both sides to schedule those, and perhaps it's not so necessary. Maybe it's that vascular complications will occur at this rate no matter what. So thanks so much for your attention. I'll take any questions now.
Questions?
Could you just tell me again what device failure is?
What is device failure?
Yeah, sorry. So we define device failure as having to use another device in there. So usually there's two devices that are placed there at the site, and if they had to use another device because it was still bleeding, for instance, then that would count as a device failure. If they had to use more devices, but later on, perhaps post-procedure or post-discharge, they had some sort of major or minor or major vascular complication, those were sorted into those two categories respectively instead of just device failure.
I don't see Mario or Paul here, but I had a question. Obviously, one of the issues here is power, is sample size. You have some trends, but they're not significant at this point. For the NCDR, we have a PCI registry that's very well established through the ACC. Is there a TAVR registry at a national level now? Does anybody know? Okay, so do all these patients get put in, but... Okay.
Yeah, and we did actually, so this one doesn't really include a control, but I've been working with Dr. Jonathan Urbach, one of the residents, and he's collected data on the control, and we've seen some definite trends between a control and the vascular complication groups here. So that's going to be something to look forward to.
Okay.
Great job. It seems like your study looking at patient characteristics, and you guys also looking at any procedural characteristics or device characteristics. Certain devices
two major closure devices when I was looking through the records that were used were AngioSeal and Preclose ProGlide, the Abbott device. We didn't really look at those particularly, but I think in the future that'd be something good to add to our table and see if there are differences in that. Definitely.
All right, thank you.
Thank you.
All right, for our final presentation, we have our Director of Prevention, Tom Knickelbine, and he is going to talk about a subject I think is very important. The Pcsk9 inhibitors were approved a couple of years ago now, almost 2.5 years ago. And at a national level, some of the feedback has been that these work really well, but we can't get any patients on them because insurance won't approve them. A couple different observational studies have suggested approval rates around 25%. And so Tom has established a system here for getting people on Pcsk9 inhibitors and had immense success. And so he's going to present some data on that topic.
Good morning. Yeah. And then I'll just switch to the other one. So this is what they call a moderated poster. It's a little different format. This is actually not what the poster looked like. It's a nice picture, but that's not it.
Okay. Sorry.
Go to. And this is oh. Yes.
It's not going to show.
That's fine. So I've taken the poster and sort of cut out each portion of it. This is a little different than the format we'll present it next weekend. But the title of our study was The Impact of a Systematic Team-Based Approach to Prescription of Pcsk9 Inhibitors on Rates of Insurance Approval and Subsequent Lipid Lowering. Here are contributing authors, and some of which are in the audience, and we have experts. Importantly, we have experts in this study in pharmacology, which, as you'll see, has been instrumental in achieving some of this result. Maybe you won't see. Not just the next page, no? Technical difficulty. Hit the next one. Will that work? Weird. I'll just close everything and restart. Check that thing, maybe. Okay, great. This one? Oh, okay. We have no relevant disclosures to this topic. So Pcsk9 inhibitors, as Mike mentioned, are newer lipid-lowering agents. They've been in the market for about 2.5 years. They're approved for patients with familial hypercholesterolemia and cardiovascular disease with suboptimal LDL reduction. And many of these patients will have statin intolerance or not adequate LDL reduction to their goal. But as Mike mentioned, the large-scale clinical use has been limited by high costs, in particular a high copay in some situations, and insurance denials that are related to incomplete documentation at the point of care and poor point of care communication. The overall national approval rates have historically been reported in the 20 to 40% range. And here is some data from the FH Foundation, published by Josh Knowles, who sort of heads up their registry. This is a national registry where they're attempting to get patients with familial hypercholesterolemia and perform cascade screening. And they went back and looked at access to non-statin lipid-lowering therapy in patients with high risk of atherosclerotic heart disease. And they looked at all patients with at least one claim for a Pcsk9 inhibitor or Zetia prescription. It's over 1 million people, so this is quite a bit of data. This is a very looked at group of people that are involved in a registry. So you consider this a pretty good scenario to detect what approval rates may be. Patients with presumptive FH, the reason it says presumptive is because they don't do genetic testing. It's a clinical diagnosis, but I can tell you most of these people will have FH or diagnosed atherosclerotic heart disease, and then they looked at Pcsk9 inhibitors or Zetia with an LDL greater than 190. You can see their reported approval rating here at 22% that was paid for. And in the atherosclerotic heart disease patient with an LDL greater than 100, which are both pretty clear indications for these medications, their approval rating at 26%. So what we did is from September of 2015 till May of 2017, we instituted a comprehensive team-based approach in our clinic here attached to the hospital to the Pcsk9 approval process. We followed specific FH diagnosis protocols, and this is important because I think people will put familial hypercholesterolemia as a diagnosis, but fail to use the accepted standards of diagnosis, which include either the Dutch lipid, Simon-Broom, or MedPed criteria. And each company may choose one of those criteria to accept as the diagnosis. A point-of-care in-house pharmacy, Epic Willow, and Cover My Meds are two areas that I don't work with, but our pharmacists do, that allowed them to complete a prior authorization process and then also have a systematic appeal process when the medication wasn't approved. The patients were divided into 3 clinical groups, much like the FH Foundation did. We looked at FH. We looked at CAD with suboptimal LDL levels or both. We looked at insurance type, whether they were on commercial or Medicare, the clinical indication, the approval denial rate, the percent LDL reduction, and patient adherence was followed over this period. The other thing we looked at is the ability to obviate LDL apheresis. We have an apheresis program here at Abbott on Station 45 in the infusion center. We right now have about 12 people on apheresis, and we looked at whether these medications, if approved, and that's very costly. That's about $6,000 to $8,000 each time, which they do every 2 weeks. Whether we could obviate that type of therapy for people. Here are our results. We had 196 patients over this time period placed on these medications. Alirocumab, 64. I'm going to go this way so I can see it, but you guys see it. 64, and evolocumab, 132. Here are statistical p-values, and I'll just kind of go down the overall results in all the patients. Mean age 62.9, 66% of them male. This is their baseline lipid profile with the 25th and 75th percentile. 223 is the baseline total cholesterol and an LDL of 148. FH was 25%. The majority had coronary artery disease only, and 22% had both. It was almost a 50-50 between commercial and Medicare. Many of these patients reported some level of statin intolerance. They still were, many of them still on statin therapy, but a lot of them had some level of statin intolerance, which is what brought them to our clinic. Our approval rate was 96%. So we did look at discontinuation, which was around 13%, and it was equally divided among side effects, cost, or patient preference. These are the change in lipids, and this really is a new paradigm in lipid lowering here. As most of you know, between Zetia and statins, we're hoping for up to a 50% reduction. Moderate intensity statin therapy, a 30% reduction. This is the absolute reduction with the percent reduction and the 25th and 75th percentile. So a 42% reduction in total cholesterol, 18% reduction in triglycerides, Actually, HDL went up 3%, LDL reduction overall of 61% from baseline. So people basically went from 148 and lost 92 points of their LDL cholesterol. This was the breakdown between the two groups, and we did see a statistically difference here. Whether this is true or not, there have been very little head-to-head between the two medications other than this. And we did see that the evolocumab group was slightly younger, had more statin intolerance, and also had a little bit more FH only, but also had a more dramatic and statistically significant LDL reduction of 65%, and the alirocumab 53%. I did go back and look at this, and what I found was, and you may not know this, but alirocumab requires titration. You begin with 75 milligrams every 2 weeks, and you titrate it to 150. I found that we did not do that very much. We got to the 50% reduction, which sort of qualifies you for ACC AHA reductions, and we didn't further titrate. That may explain some of those differences. We looked at insurance type, disease, or drug type to see if certain entities were covered and others weren't. And there really wasn't any difference in any of these categories by disease type, drug type, or insurance type. These patients were on additional lipid lowering. 40% were on some other lipid lowering, the majority being statins, or both statin and Zetia. So some of our findings, our overall approval was 97% using this team-based approach. It was highest for FH and CAD, which is basically if you have both familial hypercholesterolemia and coronary artery disease, that is recognized an extremely high-risk group, and we were able to achieve 100% in those patients. The evolocumab users were younger, more statin intolerant, had more prominent LDL lowering. The median LDL reduction was 62% at 12 weeks, 51% for alirocumab, 67% for evolocumab. That was statistically significant, but similar across the clinical groups. We had a fairly low percentage of discontinuation. The most prominent side effect that we hear about is injection site reaction, which we're able to deal with in a lot of patients with, say, Benadryl before the injection or other techniques. Our denials were for insurance type, clinical indication, and drug were similar. We did use the Amgen safety net program, which I think Sanofi is coming up with a safety net program. This allows patients that do not have the financial means, that are on Medicare, to begin use, so that the company is actually covering the drug. We were able to use that, and 15% at this. I think it's probably higher now. And then for the patients, as I mentioned, 4 patients that were on the apheresis, the Q2 weeks coming in for the infusion at $6,000 a time, we're able to stop due to the drug therapy. So in conclusion, Pcsk9 inhibitors were extremely well tolerated in our clinical practice, resulted in dramatic LDL reductions, and provided our apheresis users with a viable alternative. Insurance type, clinical indication, and drug type did not affect approval. When we looked kind of more closely at the important features for approval, it was this team-based approach with on-site pharmacy support. Proper provider documentation of familial hypercholesterolemia diagnosis and statin intolerance. Statin intolerance and FH are both pretty poorly diagnosed by the providers. We were very particular in this, using the MedPed or Simon-Room criteria, also documenting our statin intolerance, being intolerant to multiple statins in multiple different clinical categories. Electronic prior authorization and appeal procedures. And use of patient assistance programs. I mentioned the Amgen safety net programs in Medicare patients. We also used insurance copay cards and commercial insurance. And it resulted in extremely high approval rates of 97%.
Excellent. Great presentation. Questions?
To get diagnosed for this, do you have to have sort of genetic testing done?
No. So that was a clinical diagnosis. You can you mean for FH?
Yeah.
Yeah, so the two groups that are likely to be looking at this type of therapy, one is the familial hypercholesterolemia patient, and that is a clinical diagnosis. So it's based on a family history of heart disease. It's based on your LDL at baseline. and the diagnosis is made by the provider, and then the presence of any physical findings of high cholesterol. Actually, there are physical findings. One of them is tuberosanthomas, typically on the Achilles tendon. So that diagnosis is made clinically. It can be made by genetic testing. It's expensive and not covered. So we make that as a clinical diagnosis. And then the other group is just documented atherosclerotic heart disease, or cardiovascular disease, I should say, because stroke actually was included in the 4-year trial recently, so they've included that in the approval. And then suboptimal LDL reduction, and that varies a little bit from company to company, but pretty much if it's above 100, that's considered suboptimal, the goal being more closer to 70. The companies typically, will cover in those scenarios. A lot of those patients will be statin intolerant, and that's why they didn't achieve that LDL goal. Some of them just didn't get there, but a lot of them have statin intolerance, which is why we had, such a high group of statin intolerance here. So those are the two main groups that we've been approaching. I think part of our success really is that we've followed the guidelines very closely in who we've submitted in the first place. I think if you submit good documentation in appropriate patients, the pharmacy has at their disposal the criteria that company is looking at for approval, which really helps me out. I have that already before I almost go in the room. I know what insurance they have, and I know what the approval needs to be. So we can tailor it and get it done that way. I mean, that's a big part of this, how this gets done, because that national approval rating is more of just saying they have FH, not documenting the statin intolerance, not knowing what the insurance company wants to approve, and really ending up with a no, and then not having a formal appeal process, which we have as well. So it's really the team-based approach and kind of knowing what you're in for when you go in there.
It was nice to see the collaboration that brought this about. Can you just comment on the baseline lipids? Was that on treatment or off treatment? How did the changes in the Pcsk9 level, or the cholesterol after did the baseline lipids is on or off treatment? Did you look at that?
Yeah. So good question, Scott. If you remember, so 40% of the patients are on a lipid-lowering agent going in, and they have a baseline LDL of 148. And that 148 dropped 92 points, or 61% in the group. And like I said, that is a new paradigm in lipid lowering. To be able to drop LDL by 61%, was sort of a dream 4 or 5 years ago. And this is in the face of an extremely well-tolated drug with 13% overall discontinuation and only a 4% discontinuation due to side effects. So, this is kind of jaw-dropping in a lot of these people, especially the FH patients. A lot of them haven't seen lipid levels that we're achieving in their entire life. Maybe something they got drawn at 12 or 15 years old and were told they had a high cholesterol. They've never seen numbers this low. And we do know that correlates because of the 4-year trial, which is an outcome trial with better clinical outcome, less cardiovascular event rates, at least in the patients with coronary disease. And then Odyssey Outcomes is also going to be presented right after this, which is the alirocumab outcome study, which we are a part of, the Odyssey Outcomes trial, which is acute coronary syndrome patients treated with Pcsk9 inhibitor. It's a longer duration outcome than with 4-year, and it'll be presented at the ACC right after this. I think about 1 o'clock.
Yeah, Saturday.
Saturday.
Did they titrate in Odyssey? You mentioned the titration of the product.
They did titrate. So that's one thing that I don't think we did a very good job on, but it's real world. Maybe this is a way to say, do we need to go to the 75 and then the 150? Should we go going straight to the 150? What Mike's saying is with this medication, it requires the provider to change from 75 milligrams to 150. And the evolocumab, not so. It's 140 every 2 weeks or 420 a month, whichever the patients prefer. Most people prefer the 2-week injection. And we did not do the titration. I think we did it once in this group. So our LDL reduction was a little less prominent in that group, but we also achieved the ACC-AHA LDL reduction target, which is 50%. So I think if you achieve the 50%, do you up-titrate or not? So in Odyssey, the outcome trial, it's more of a controlled study. They tell you, that you're supposed to do then, I think, is wash closer, and they did titrate up to the 150.
And I don't know, question maybe for Susan or Sam, what percentage of patients require an appeal?
You know, it's so different from what we started out doing access to what it is presently. I mean, initially, gosh, I'd say a third of them, and then now presently, less than 20. Yeah, it's dramatic.
Yeah, it's a little bit of warm down, but it's also, there's a bit of trust, I think, that you build with companies. They know we kind of have a lipid-directed clinic. We've only sent them pretty appropriate patients with very good documentation. That really works in your favor, and it's, again, why the tertiary center that maybe does have the ability to put a team on this is much more successful than if you're a single provider. And this would be very hard to do, I think, without having a specialty pharmacy on site, without having a pharmacist in the clinic with you. Susan has been instrumental in really following up on this and actually started the database for us. So it's been a team approach.
I think as a practice, it does really help that the other drivers are actually sending the patients to the prevention.
We have had, you know, some of our partners, even our partners try, and it can be difficult. They can miss one of these key elements. Once you get a denial, it's hard to reverse. So we've encouraged people to send them our way so that we can give the patient their best shot. You get one shot usually. When they do a denial, they really don't want to go back and undo a denial, but they will if you resubmit documentation, but they tend to look back at the documentation and say it's still denied. So at least for now, based on what we've got, we've given the patients their best chance of getting approved by coming to our lipid clinic, our preventive clinic here, seeing either Mike, myself, Sandy, one of our providers, and getting them this kind of approach.
How many patients came off of statin after started there?
None. So we don't do that. That is not recommended. It wasn't done in any of the trials. You know, the amount of outcome data for Pcsk9 inhibitors being about this big, we have 4-year, basically it, now to come Odyssey. 4 years, 20,000, Odyssey's 25,000. Statin outcome data, you know, in the hundreds of thousands if you put all those together. And the statin clinical data, and the statin's also having some potential pleiotropic anti-inflammatory effects. We don't, and you're not supposed to take anybody really off your statin. We may adjust the dose. We've adjusted the dose occasionally in a Pcsk9. We've adjusted the dose, like maybe we've taken them off of their Zetia, for example, kept them on their statin, but we don't encourage anybody to come off their statin therapy when they begin Pcsk9 treatment.
The notion of statin intolerance, so 86% are statin intolerant, yet 40% still on the statin.
Well, statin intolerance is maximum tolerated statin. So you can be statin intolerant to 40 of Crestor, for example, and still be on 20. And we have a lot of people like that, or 10, or 5 every other week. Statin intolerance is any level of statin intolerance, not absolute statin intolerance. So it's a gradation of statin intolerance. Or you might be statin intolerant to a certain dose and then able to tolerate a lower dose of a different drug. That's any statin intolerance. But 40% of them were on some sort of statin. And that's pretty much what you're going to see in Odyssey outcomes in 4-year. In 4-year, 95% of the outcome study were on a statin. Only 60% were on a maximal tolerated statin. They were on the high intensity. But most of them are on a statin. And that's kind of our goal here. This isn't to obviate statins. We're not trying to get people off statin therapy. We don't mind getting them off apheresis, but we don't want to necessarily get them off statin therapy.
Excellent. Thanks.
Before everybody leaves, anybody that's attending ACC, there are postcards out there with our newest journal information for the Journal of MHIF, and then there's also a flyer for an April session. If you need any other, and there's business cards as well, if that would be easier for you to